Alright, let's do this here. A few people are probably filtering in now. It's a long walk from downstairs. Thank you everyone for coming. I appreciate the trek up from the basement to come see us enjoy our presentation here. My name is Tim Spaeth. I am the Senior Vice President of Payer Solutions at Episource. With me is David Meyer, who runs risk adjustment for SCAN. I think most of you probably know Dave relatively well. Hopefully we'll have full insight for you guys today, but I'll take 2 seconds and give you my kind of infomercial propaganda spiel on Episource. Really, with that Episource, we're really trying to simplify healthcare. You'll see a lot of our solutions are really trying to take out the kind of the challenges of healthcare, make it an easy kind of solution for you guys to really focus on helping your membership. A couple things that we do. Really, our bread and butter, kind of our core offerings, always been charts. That's where we've got our start a handful of years ago. This year, actually, we're doing 4 million charts in terms of retrieval and coding, both on the ACA, and on the Medicare side, as well as doing fetus abstraction piece. But in the last couple of years, we've actually moved over to the EDS side of the world and the analytics side of the world, and so that's where we started to focus and started to have a much more kind of one-stop shop offering. That's it on my piece. I am going to turn it over here to Dave. With Dave, he knows, everybody knows who Dave is, so I didn't even give him any time to get his own spiel in here.
I got no slides, no introductory slides whatsoever.
He did wear a jacket, so if you guys, any of you know Dave, that is big, so I appreciate
it. This is only for AHIP, for anybody in the room.
So anyway, want this to be a little interactive, so if you guys have questions, please shout out or give us some questions. I'm going to ask Dave some questions and kind of go from there.
And then Tim, we talked about making this very interactive.
Yeah.
I mean, I think the traditional 1980s style slide lecture, 10-minute at the end Q&A. We just don't want to do that. So as we go along, I see a lot of faces that I know. Sean threatened to come sit up front and interrupt a lot, which if he's here yet, I don't see him yet, but I hope he does. So please feel free to interject as we go along. I just think that makes it more fun for everybody.
I mean, we'll definitely have questions at the end, but please, as we're going, I've hit a lot of topics, so please. Anything else you want to say? Anything you want to say about SCAN?
The first thing I'll say about you guys, if you ever want to know what is going to be hairy in the industry, look at what all the vendors are investing in. So Tim said, well, they started, bread and butter was around retrospective coding, chart reviews, right? And notice that they're going now heavy into RAPS, EDPS submission and reconciliation and the analytics around it. And I think that that's always a great bellwether for a health plan to get a sense of what's about to go down and what's going to be hairy is where people are investing. And so I think I appreciate the fact that Episource is investing in this area. I do think it is going to be a hairy area for our industry, so I appreciate that. So about SCAN, we're the 4th largest MAPD, not-for-profit. So that's the qualifier, not-for-profit. I like to add it, just at the end. But based in Southern California, and what do I say about SCAN? We're extremely proud of our member sat, of our stars scores. Albeit we've gone from a 4.5 to a 4, and if anyone wants to buy me a cocktail later, I'll take you up on that. We could talk about why. But yeah, no, it's a great organization, and the only that I know of not-for-profit public benefit company in California. Kaiser is not-for-profit, but I don't think public benefit. So anyway.
So at AHIP, there's been a lot of policy discussion. We will have one slide basically on policy, and then we'll try to get into some real details. But why don't you kind of give us a little background of why you did this, why we're doing what we're doing here?
We have this. So Sean Crichton and I spoke a number of months ago together, and one of the things that we built into that deck, and I included it here because I think it's worth noting, and I'll completely do the shout out to Sean. The intelligence on this came from him. But as the agency looked at building out EDPS, there were 3 primary drivers for this, and it's worth keeping this in mind as we have this discussion today because it colors the rest of our discussion. So 3 main areas that they were interested in. One was around risk adjustment, the agency was very interested in having the raw data with which to build out and to enhance and potentially even completely change risk adjustment models. So huge driver as to why they were interested in having full encounter data to modify the system. Utilization, I mean, I think that's relatively straightforward, sort of line of sight as to what we're actually delivering. This really comes back to that, are we delivering, value as compared to fee for service, that kind of a question. And then finally, it's kind of calling BS on health plan bids. I mean, CMS, they have color, but they didn't have really sufficiently robust enough data to really challenge health plan bids. And I think I would expect that we're going to see, instead of just the year-over-year comparisons that we've historically gotten from CMS, why this changed last year to this year, I think we're going to get much more challenging questions in the future. So these three primary drivers, and we're going to be talking primarily about the top one today.
So been working with EDPS now for, I guess, 5 years, pretty much, working with the data. I think, dealing with a lot of clients and a lot of health plans out there, you guys seem to be at least at the top of the echelon and working the data from day one and kind of dedicating a lot of resources to it. And so now we've had a few years, obviously financial pieces are in play now. What have you guys kind of been doing at a macro level at this point? What have you guys kind of been doing to try to understand this and try to get your arms around it?
So it's true, SCAN was an early adopter of leveraging EDPS data, trying to get a sense of where the government was going with it. And so the longer you've worked with EDPS data, generally the higher your frustration level. So for those of you who've been working with EDPS data and you're smiling, I know you haven't been working on it for very long. So EDPS data, particularly the MAO4 files, which we finally got, and were really problematic files, without line of sight too as to where those gaps were coming from. I think we can guess at it today, and there's some rumors in the industry about where they're coming from, which we'll dabble into. But yeah, SCAN was an early adopter, and one of the things that we did is we tried to take this new data source and ask the analytic question, if CMS uses the logic we think they're going to use, what would revenue look like shifting from RAPS to EDPS? This is an early question we asked. The percent impact we had initially modeled was about 1 to 2%. So that was based on our assumptions of what CMS would put into place before we even had good color. Now that we have the existing what I'll call the old MAO 004s, I can tell you that number is higher, that percentage is higher. And with the new MAO 004s, which have just become publicly available within the last day or so, and unfortunately, my team, I'm too physically far away to yell at my staff effectively, so I don't have new color for you on the new MAO 004s. But for a little bit of color on this from Sean, because he was involved in a pilot. The sense is that the gap did substantially close with the new MAO 004s, but maybe not completely. So I think that's sort of a TBD. But yeah, we were an early adopter, and one of the things that we did also early on is start to push the color to our medical groups. And part of our conversation today is going to be about health plan impact. But to be honest, we kind of thought that you all have probably seen one or more presentations already on health plan impact. And so what we wanted to do is take the conversation to the next step, which is down to the medical groups and the providers and what we think is going to be happening today.
So before we do that, I know you have done a lot of work. Your team has done a lot of work on this. So there's a slide we have. I want to kind of let you walk through a bit. I think it's pretty impressive.
Oh yeah, no, this is fantastic. So I asked my folks to pour through the MAO04s, analyze it, and come up with something clear that I could present to senior management. And they came up with this thing. And I swear to God, it's literally like your dog or your cat bringing a dead animal and dropping it on the doorstep, and you sort of have to stroke them and thank them, and then quietly throw the thing out. So anyway, so they gave me this, and I literally, they were proud. Look at those blue lines. It's like a flipping spider web. So anyway, a couple hours later, why don't we just go to the next? A couple hours later, what we cut down is to this, which as an executive now, I can buy in to this. So this is what I want to lead you through. So top line, and this is again old MA004 data. Okay, so that's the big asterisk. Top line, scan sees a 10% hit to revenue, of which 4% is due to what we think are incomplete MA004s. We expect that 4% is going to close with the new MA004s. Now, I don't know that that's true, but that's our expectation. So that gives us a residual 6% revenue impact. And that splits evenly, roughly, and obviously I dummied up these numbers a little bit, roughly though, between data going in on the RAPS side only and an actual logic difference with EDS. So if you think about that top line number, the 6%, Tim, I know you've looked at this with your client base. I mean, Sean and I have had a lot of conversations about this. I know he has a number very similar. It's slightly lower. I think his is like 5.5%. Tim, I mean, where are you?
I mean, you guys are definitely, as I said, you're in the upper echelon. I mean, the 3% is kind of the minimum we've seen for most of our clients. You can see it can get up closer to that double digit, not depending on the client, but it's something that the industry, and you guys have been working on for 5 years, really dedicated. Now, a lot of the industry, not saying people in this room, but a lot of the industry has taken their time, and now all of a sudden, now financially, it's impactful. So now they're starting to look at it, and unfortunately, these are bad enough, right? They're not good, but these numbers get higher for a lot of the health plans out there, and we'll get into the medical groups in a moment, and it's even a little bit scary. Right?
Yeah. So I mean, so the 3% on the far end, the logic impact, that's in a sense more or less a non-modifiable number, or only slightly modifiable. My boss and I think that if we really work hard and and are creative, that we might be able to get into the high twos. But we think that that's probably going to be where scan ends up. So certainly happy to solicit this. I mean, has anybody looked at this for your organization? And curious. I mean, does mid-single digits something that you're willing to say roughly is where you're at? Are you higher or are you lower? Anybody feeling brave? No, nobody's had a cocktail yet. Okay, that's fine. So anyway, I think that 6% is actually kind of in line with what a lot of people are saying. Diane?
Dave, as you guys put these percentages up there, are they percentages of differences or revenue? That's revenue
impact.
And so it's
3%. Right off the top. Any other questions about this? And I have the other slide, so if you guys piss me off, I'm going to go back to the other slide and bore you to tears with what my I'm going to bore you to tears with this. So anyway, let's go past.
All right, yeah. So in this industry, we've always been focusing on submissions, and that's for the last 4 or 5 years. Submission.
Yeah.
No financial impact. All CMS says is we got to get the submissions in. Yeah. However, there's another side of that. What else needs to be done? What are you doing as a health plan? What do you think the industry should be doing? And are there things that are potentially being missed out there today?
Yeah, I mean, in terms of, we decided to go with just images on this. When you think about how health plans are trying to protect themselves, this issue around making sure that we correct data that has been declined or denied, and treat our programs upside and downside evenly. These are two topics that I think a lot of us struggle with on the plan side. My expectation, and just conversations at conferences with other medical groups, my sense is that a lot of medical groups have programs around RAPS, but those programs don't clean up data around EDPS. And so for those of you, that are executives at your health plan and don't have line of sight operationally to what's going on around that, I think that ought to be, kind of like a homework question for you. When you get back, ask, so what are we doing to clean up RAPS? And then what is our how do we handle EDPS, and are they roughly equivalent processes? My sense across the industry is the answer is no. And I think there's a couple places where no becomes the strongest, and the first is around deletes. So, I mean, as everybody knows, CMS has asked us to send full, complete, accurate data, all full, complete, accurate data to CMS, and they're going to apply the RAPS filters, right? Which I still maintain is exactly like taking all of your receipts, putting them in a shoebox, and sending them to the IRS and having them tell you what you owe, which still doesn't make sense to me. But anyway, that's fine. But you know, we've done that as an industry, but I don't think that we have actively cleaned up the data. And I think, and to some degree, for probably a lucid policy reason, right? You know, CMS has indicated that we're supposed to keep everything stored. They'll apply the RAPS filters. And I think a reasonable person might say, well, okay, if you're going to apply the filters, it's on you. What does RADV, though, mean in an environment where the government applies the filters? So if we have, as an industry, no responsibility for which data is used for revenue purposes, and the government asks us to send everything, is the health plan continue to be culpable for data that's unsupported? Obviously, I think the answer is yes. So you go back to this issue about, well, the government's asking us to send everything. What does everything mean in an environment where we're still on the hook for audit? And I think, and I'll just say, you know, my recommendation, and to some degree what we've adopted at SCAN, is a modification of this. We send everything, we keep those data stored, and at the end of the period, right before the final submission window, we do a large redaction with CMS for things that we don't want to be included in the model, the payment model. And in an ideal universe, the EDPS format would have a flag, right? Use this for revenue, don't use this for revenue. We populate it with ones and zeros. We don't have that. So that's the way SCAN's handling it. There's a wrinkle to it, and you know, obviously where there's 5 or 6 diagnosis codes and you're removing one that you don't want to be used for revenue purposes, the counter still stays submitted. To the degree that there was just a single diagnosis code submitted initially, you're now removing evidence of that face-to-face visit. And so the way that we're handling this is to document the fact that we're doing it. We're documenting the impact, the number of E&Ms that are going to be removed altogether, kind of summarizing what those visits were, you know, in terms of complexity, and summarizing some of the diseases. And we're going to be providing that data to CMS, but we are going to take the step to remove data. So anyway, I would, you know, to the degree that you don't have this as a clear policy at your health plan, I think it's something you need to think about. Obviously, every organization, based on your risk tolerance and your existing operations, you may come to a different conclusion than SCAN. But I definitely think that this is an area that a lot of health plans just haven't thought about. Great controls, great line of sight to the logic around RAPS, and scant, if any, controls around EDPS. It's considered transactional, and I think that's a mistake as an industry to consider this just purely a transaction.
Well, I'll add a little color to that I've seen some of our clients that we've been focusing on, obviously, EDPS. RAPS pretty easy to delete. It is just to say that heap, right? That's why you put in the RAPS file, you delete. EDPS is you have to delete the claim, or you have to make some modifications. But what we've seen, and obviously still working on 2015 days service, obviously 2016 days service. But with 2014 days service, you know, I'm not sure a lot of people realize that it actually was in play financially. With the 2014 days service, it was a union. So CMS was going to give you credit if you had a DX on RAPS or on EDPS. If you had them both, fantastic. But if you had one or the other, you get credit for it. RAPS, people deleted it like they should. But what happened is that data was submitted for EDPS submissions, focus on submissions, get that data in. It was never deleted on the EDPS side. And so what we've seen is when the final payment came out past July or August, that all of a sudden the final payment was a lot higher than expected for a lot of health plans. A lot of health plans like, hey, great, we got a lot more money than we expected. But a lot of the ones who realized it said, wait a second, we didn't expect this, and there's a reason for that. Oh, we didn't delete that. And now they're having to take accruals. Some are working on trying to get this deleted, but I still think there's some out there that are just kind of cheering and saying we had a great year, a lot better than expected, a lot better results. But that's the scary part of this. And I still think that is going on with 2015. And kind of going back to your RADV, I have a belief that CMS is looking at this data. They have analytics engines. They're not just looking at the data. They're trying to make better policy, trying to make better models, all that, but there's also the RADV component. I mean, what are your thoughts on bringing in that the analytics side of things, even from a CMS perspective? We should probably do it from a health plan perspective, but is CMS really taking that data? I've heard you talk about RADVs in the past. I know they're one of your favorites, especially these days.
Yeah.
But kind of going a little more into that, how do you think CMS is using that data on the RADV side?
Yeah, and what I'll say, we literally just got done with the appeals phase of our 2007 RADV, and we're in the middle of a 2012 RADV right now, which is what Tim is needling me about. So thank you for that. But yeah, I think from a RADV perspective, and again, scans take on the data that we keep stored with CMS has been relatively conservative. We cull through the data, and I'm just going to give one or two examples of things that we're actively removing. We cull through the data for single incidences of cancer, AMIs in office settings, and where we don't see any pharmacy to support the cancer, where we don't, an AMI in an office setting where there isn't evidence of an inpatient within a very, very close period of time. We actually are now treating those. We used to do an audit on it. Now we treat it as a pen. So the data just doesn't go out the door to CMS. I think as an industry, Spinal E is up and coming. So if you're not sure what I'm talking about, you can come see me later and we can talk a little bit about this. But I think that there's a number of disease states that are absolutely on the radar screen. Spinal E is one that CMS has commented on recently, and I think we're all advised to focus on that. So with RAPS, and I said this at a conference like maybe 5-6 years ago. I was saying to people, if you really wanted, and I will tell you, I've never done this at any of my health plans, but I was just doing this as a thought experiment. I was saying, well, if you really wanted to make it hard for CMS to cherry pick in a RADV audit, what you do is you only send every HCC once. So CMS they don't have the peaks and troughs for an HCC. The concept of, for instance, a single cancer code submitted once, now they're all submitted once, right? So you've flattened out the field, and it's analytically impossible now, with the exception of pharmacy data, but very difficult to get a sense of if you wanted to cherry pick where to go. And I meant this as a thought experiment.
I know certainly health plans who did that.
I know health plans now have done it too. So anyway, but we never have. But I think that one of the things that happens with EDPS is that goes away. There are health plans that have embraced that kind of strategy. May have come up with it on their own. It may not have been my idea for them to do it. But EDPS knocks that out. And for those of you that listened to Tom yesterday and maybe caught him after and kind of teased on this RFI, and if you haven't read it, it's a painful read, but it's totally worth reading. The RFI for the RAC auditor. You get a very clear sense that what CMS is looking at is a traditional RADV, 1 year for every health plan, and then a targeted, what statisticians might call cherry-picking orientated audit the next year. And so all of a sudden, some of the things I'm talking about, AMIs in office settings, which largely are unsupported by the chart, single incidences of cancer, Spinal E, which is again on the radar screen, things like that suddenly become low-hanging fruit for a RAC auditor. And I personally feel, and I have no line of sight, into the agency on what they're going to do, but I just approach this from a business standpoint. if the RAC auditor does a RADV 1 year, they're going to, so you do the audit. I mean, what's the line, the length of time? So you do the audit, takes 6 months. Then there is the review, then there's appeals. I mean, and I just told you, our 2007 audit, we just got done with our appeals phase. I mean, so what's the length of time you have to wait for payment? Well, as near to forever in MAPD as we have, right? So what is that auditor going to want? And they're going to want something that improves their revenue stream. So okay, CMS, I'll do the traditional RADV for you, but I only want to do that on half of the health plans. The other half, I want to do something targeted on specific conditions that I know I'm going to get a clawback, and I'm going to get that 30% or whatever of what's captured, and that's going to float the RADV activity, which basically won't pencil out. I'm going to throw a whole bunch of resources towards it, and I'll never get there. So my instinct is that that's where they're going. It's in the RFI in terms of this dual concept, but I think it absolutely will happen because I can't conceive of a payment strategy that would tempt somebody who wanted to be the RAC auditor unless they had something like that. And Tom pointed out too yesterday, and it was worth pointing out now. I mean, who knows how long the strategy stays in place? I mean, it's a very cumbersome strategy. If we start seeing really, really high error rates philosophically, what does that mean? I think I would just encourage you, if Tom is still around, for those of you that have policy interest, I think there's a really interesting discussion around that. But yeah, no, I think RADV is absolutely facilitated, and particularly when you think of the RFI, the two kinds of RADV, that traditional random sample or stratified random sample, and the new HCC, disease-based, cherry-picking-based.
I think it makes it critical for health plans and groups at that point to start doing analytics, to understand what those outliers are, and really have to focus on. You guys are doing it, bringing out these examples, but if you're not, you're going to get caught and say that CMS is going to see it. They're doing analytics. They're going to find it. Kind of close this out and get over to more on the provider group level. Talking about provider groups, there is abrasion. And you like to talk about abrasion, but kind of as we transition, let's talk about abrasion and then how we're going to have to deal with the provider groups going forward.
So my boss Moon Leung and I, this is our attempt at a cartoon. We think that this is wildly funny, by the way. So it's okay if you don't laugh, but we think it's funny. But we believe that this is where the industry is headed, and for a number of reasons, right? The existing burden around HEDIS and STARS, the chart review, intensive strategies of a lot of health plans towards fixing revenue. They don't have upfront programs. They're catching things on the back end. All require pulling people offline at the provider office to grab charts. And you think about the RADV conversation we were just having. Well, 201 members with a random distribution of HCCs per tertile, that's not going to produce a ton of chart asks, maybe 1,000, 1,500, something like that. But if you do targeted chart audits, right? So go ask your analytics department, how many single instances of cancer do we have? How many AMIs in an office setting do we have? And start adding those up. The amount of charts you're about to ask for limited to no return is going to be gargantuan, right? We're going to flood the providers with these asks for charts, and therefore I think as we're reaching this critical time, CMS in their advice to health plans getting this year's RADV cautioned us to be very careful about provider abrasion and about what we ask for. So I think the pushback from the physician groups, from CAPG to CMS, is being heard. I think that they're concerned about it, and the reaction is not to remove the audits. The reaction is to focus on the health plans and our operations. So we produce all kinds of data, though. In terms of overloading the groups, SCAN has been an early adopter of pushing data to the medical groups. I mean, I see a couple of colleagues that have operations in California. I know your health plans do the same thing. I don't think that there's a lot of secret sauce there now. I think there's a lot of very similar reports, and somebody's health nets is blue and mine is green, but I mean, they're basically the same data. But a medical group is not, they're not really looking at 8, 10, 12 different health plans reporting. They're just not looking at it at all. So what I think is happening is that the medical group's reaction, in a sense, the abrasion from the analytics that we're giving them is to just step back altogether. So SCAN has done something that I would encourage you all to think about, for those of you that are on the plan side. What we've done in our EDPS error reporting is not to only give them the ones, the errors that are tied to revenue, but to flag them, to allow them to prioritize errors that have known financial impact. And I think, frankly, in terms of low-hanging fruit for the industry, I think that's something that we can all do that would be dramatically helpful to the physician community. So I understand in California there's very few health plans that have adopted that at this point. I'm proud that SCAN is sort of an early adopter of it, but I really do think that's someplace that we need to go.
Yeah, I agree. I mean,
because they're not working errors.
They're not. And in California, these provider groups have 7, 8 health plans they're dealing with, and and I think there has to be more of a partnership. I think at times there's been health plan versus provider groups has always been like this, and given abrasion because of charts aren't going away. They're not. You really need to kind of bring everybody together. And I think the sharing of data is critical. There's been always, I want to share that data. You guys seem to do a very good job. There's a few other health plans out there that do a good job, but also the provider groups really need to be able to handle that data, understand it. And then as we've kind of gone through it, now we'll get into a little bit more micro here. You have a lot of providers. We have some data that we'll look at here in a second, but let's kind of walk through what you're seeing with your provider groups and then how you deal with them.
Yeah, I mean, so just to remind you all, so from a health plan perspective, again, it's 3%, right, for SCAN. So when we get up in the morning, we think that's our EDPS liability is about 3 points. But for the purposes of our presentation today, I just ran EDPS impact across our network. And I see basically more or less 2 groups. There's sort of the yellow group, which is sort of relatively flat and clustering in and around the SCAN average. And then there's a mode, a group of medical groups that have just shockingly high EDPS impact. This is where my head is going right now around EDPS. I think health plans absolutely have to put programs into place to mitigate that 3%. And again, SCAN has to work really hard to get to 3%. Remember, we're really at like 6.5%, and that's assuming that the MA004 data comes in the way we expect it to. So we got to work from that 6.5% down to 3. But this is assuming the 3. This is assuming the 3, that all the work was done, that we've cleaned it all up. You're still seeing some medical groups just absolutely devastated by the phase-in of EDPS. And I think that this is going to be the absolute unintended consequence of the phase-in of EDPS, is chaos within your network. And to my knowledge, I have not heard anybody at a conference bring this up, so one for Dave Meyer. But honestly, I'm worried about this. And if you don't mind going to the next, so Tim and I were chatting about this and just trying to think about how we could cut this data to leave you all with something interesting and give you sort of a next step. We cut it in a sense by medical group size and sophistication. And the groups in the middle are sometimes squirrely because you could be large and low sophistication. So anyway, I mean, this is not exactly publishable in JAMA, okay? But we came up with 3 categories. So we got high, medium, and low. And I want to point out that just the low is bigger. The low sophistication, low membership groups are bigger. And so what does that mean for your network? Well, in a sense, the 80-20 is probably covered for your networks. You all go out, you're going to work this thing hard. You're probably going to have 80% of your lives covered. But 20% of your lives, roughly, are going to be covered by parts of your network that are going to be absolutely devastated by the phase-in of EDPS, particularly if you have a percent of premium strategy, which we do at Scan. So this just flows. This clock is wound, and there's nothing we need to do, right? So what you have is sort of the ticking time bomb for the most vulnerable parts of the network. And where Scan's head is at is our most vulnerable parts of our network are, quite frankly, in some cases, mission areas for us. You know, parts of our network that we wanted to expand in, we wanted to get into because we wanted to help that particular population of people. I don't want to see Scan's passion project blow up. So you know, here's an example though of where, to my knowledge, you know, we don't have a good contractual mechanism for supporting, alleviating the pain for those medical groups. It's just not the way we're set up today. So I would caution you all. If you know, I think this is the untold story with EDPS. Yeah, you're going to have a revenue impact on the plan side, and I think that's going to be tough for you know a lot of us to handle. But I think it's downstream that really, because of the tails. I think that the downstream tail, and particularly for the small, low sophistication medical groups, I think is going to be really bloody.
I have a few minutes here. Open up for any kind of questions that anybody might have on anything we discussed.
Yeah, please.
Good question. Where do you guys see the EMRs and interoperability and that coming into play compared to the integration that we're seeing on the chart side? And how long do you think that evolution?
Yeah, so this is the distant, happy future that we all envision, right, Diana? And the question is, how long does it take a health plan and a medical group to agree on how to share access to the back end of their EMR? And the answer is it's measured in decades. Right? So, I mean, and even if, you know, again, we're not for profit public benefit. I mean, if a medical group is going to let anybody play in their data, it's going to be us. And we have conversations ongoing, right? You have people that are willing to talk about it. Do we have a deal? Do we have anything up and running? No. So I think it's something, and particularly, you know, you're on the vendor side with TriZetto. I mean, I think it's something that we as an industry want to see happen, because we think that that's probably one way we mitigate the impact of some of this, particularly, for instance, provider abrasion, right? But getting over the distrust, getting to a place where we're allowed to all play with the same bucket in the same sandbox, I don't know. Anybody else? So yeah, it's always my goal to thoroughly depress people. I usually talk about RADV, the future of risk adjustment, or EDPS, and they're all bad stories. So it doesn't surprise me that you just want to get out of here. But I hope you enjoy the conference, and I hope you learned something today. This was helpful.